Recording. Okay. Welcome everyone to meeting 5 of the governance tag. My name is Laurel Swordlaw. I'm with the Oregon Health Authority. Let's take a look at our agenda for today. We're going to start by reviewing some of the feedback that we got from the task force at the most recent task force meeting, which is on the deliverable to date, the document that attempted to outline the decisions that you all have made over the course of the past 4 meetings, specifically honing in on the role of the single payer, the role of the regional entities, and the relationship between the two. We're then going to return to the conversation that you all started at your last meeting regarding the fiduciary responsibilities of the single payer and any specific responsibilities that the single payer has as a public trust. And then lastly, we're going to discuss any of the authorities that would be needed in order for the single payer to function in the role that you all have laid out. Can I pause here and ask, is there anyone wishing to provide public testimony today?
Yeah, this is David Ledwick. Just 3 or 4 minutes. I was going to do a document, but I don't have it ready. But I'll just refer to the one that will be coming, and it'll be ready for this group's next meeting, and certainly in time for the overall task force.
Sounds good. Thank you, David. We'll make sure to leave 5 minutes at the end for you. So before diving into all of this, I actually, we wanted to check in with you regarding the goals for today, but also just the overall work plan. If we're able to get through all of the content today, the tag will have completed its charter. And because this tag has been operating in such a way that you have in essence been drafting the report along the way, we actually anticipate that the next meeting we may have 1 or 2 loose ends to tie up, but we're actually proposing here that we spend the next meeting to try to outline some potential governance items for the possible extension. And so we wanted to include this at the beginning just to kind of help frame out the goals for today, because our goal for today really is to attempt to wrap up your charter for the tag. And so to do that, that's going to require, again, finishing up the elements with respect to the fiduciary requirements, and then also having the conversation about the authority needed for the single payer and regional entities to serve in the roles that you've all outlined. Any questions on that? Okay, we'll talk through the process for giving feedback on the proposal at the end, just to make sure that everyone, I don't want you all to feel like this is, speak now or forever hold your peace kind of thing. We'll still have time to kind of check in on the proposal. Okay, I'm going to hand things over to Janine.
So we just wanted to kick off with a review kind of to acknowledge some of the adjustments we made, although I don't know there's that many on some of these first couple of slides from last time, but we had talked about the roles of the single payer, of the regional entities, and then a little bit of the relationship between the two. So the language on each of these two sides of this slide are basically what you had put into your outlined in your roles document that went to the a full task force as a beginning document. So I think what we made sure of was we changed the arrows so that it was two-sided, was the making sure that there was a relationship back and forth between the regional entities in each region, as well as the single payer. So the next slide, Laurel, unless anyone had a comment there. And then again, kind of just cleaning up the visuals that we used last time is we added this collaborate to represent the collaboration. I think Deborah brought this out, that there would be collaboration, sharing of good ideas, best practices, et cetera, between the regions, as much as there would be amidst the single payer and the regional entities. Any questions or concerns about that slide?
I think that one thing that John brought up that I just want to chime in for him because he's not able to look at the slides. When he and I checked in, he did kind of highlight that we probably are going to want to have in the final visual, that is, if there is a visual like this included in the final deliverable for this tag, which I think could make sense. He highlighted that it might make sense for the overlap of the delivery system and the single payer to be larger, to really make it clear that the single payer is the one that is doing that contracting with the regional entities. So Janine, you and I can check in on how to frame that out, but I wanted to offer that that reflection back out to you all.
Okay, so we can adjust the size of the circles to reflect that better.
Yeah, and the overlap, I think,
right.
is the, yeah.
Right. Yeah. Okay, so next slide. So roles, relationships. Next one, we talked about the flow of funds with adding a lot of dollars between the single payer and the delivery system, because that's where the bulk of it due to the direct services. And then some dollars that would fund activities in the regions overseen by the regional entity, including some health improvement, some capital investment, and ongoing stakeholder engagement. And then we just had a dotted line as a possibility if there was any potential of using the regional entity as either a third-party administrator or what's ASO. I'm blanking on what the A is in ASO.
It's administrative, right?
Administrative services organization that would potentially be in there. But the essence of the larger picture here is just that the bulk of the dollars would go directly to the delivery system, and less amounts, but still significant areas of importance that the regional entities would be in charge of. Any issues with this depiction, concerns? No? So you presented all the roles, responsibilities, and the flow of funds to the last task force, of which you all were there. And some of the feedback is outlined here. Was raised that the region should be involved in ensuring that the community's voice is heard, that they're engaged and involved in all of this. There needs to be ensured that there is enough dollars to go to at the level of the region to enhance that engagement. Flexibility for the single payer to decide on, not to determine this group to determine it, but let single payer down the line decide if they wanted to use a regional entity as a TPA or ASO. And that there was a clear relationship with the key role of the regional entities would be tracking all the regional jurisdictions, serving as a conduit to local public health authorities to enhance the communication with the single payer. The conversation you had at the task force was to be kind of vague at this point on who and how and what a regional entity is, and how it should be formed, but that could be determined at a later point by the single payer. There was some discussions about entities like the regional health equity coalitions, which are not across the entire state at this point, but in many areas of the state, as a potential prototype to look at, and making sure that there's some thinking about what is going on in the various geographic regions that could be aligned with those decisions that the single payer would make about the regional entities. And then the conversation also led to thinking about CCOs versus that we have now versus the regional entities, and that the sort of the insurance function of what CCOs do now would be dissolved because it would be taken on by the single payer. but that the CCOs, there may be entities that may want to remain and become those regional entities and organizing themselves to fit whatever criteria the single payer would set for that. Does
Bruce,
that?
did you have a comment?
Yeah, I was going to say, I don't know that the wording of being intentionally vague was appropriate. I think it's more about putting all, deferring, deferring how the regional entities will be formed till later. I mean, intentionally vague sounds a bit nefarious, and I don't think that was the intent.
Yeah, you're just not going to make decisions about that at this point, but
Exactly.
will be determined later. Okay. Any other feedback that others heard that we were trying to capture? Laurel was trying to capture here the essence of the conversation as you think about going forward and clarifying and finalizing your proposal. Any, Deborah, Chuck, anything else? No. John, are you, if you're still listening? I know you can't raise your hand, so.
No, this is great with me. I agree with Bruce. I think that language could be changed a bit. You know, the bullet about the key regional entity roles, those are two different things to me. And if this is ever listed as, you know, I think it'd be appropriate to have regional jurisdictions, and then you know, something separate for local public health. That's just me. I know that public health is within those regional jurisdictions, but I would think about separating the two.
Okay.
It's a minor point.
Right, because there's also mental health and other jurisdictions, so to speak, in there, but you wanted to really highlight the public health aspect of it. So.
John,
yeah.
I made that correction on the slide, just so you know.
Yeah. Yeah, you know, mental health is part of the delivery system. I mean, public health, I think, just as we're seeing, has this very unusual role. And I think we should communicate an appreciation for that, and you know, reach out to them in a special way.
Okay. All right. So with that, we'll move forward to, we talked at the end of the meeting about some fiduciary responsibilities, and it was raised that, you know, it was larger than what we had on that particular slide that we were discussing from at that time. But so we tried to capture all the differing fiduciary responsibilities that we could think of based off of thinking about those roles and responsibilities. So obviously there needs to be a single payer budget and the single payer would ensure that there's adequate resources for both the covered services and administration of those services at the single payer level to achieve the goals and vision of the single payer program. They would also need to establish and ensure there was appropriate restricted reserves as any because that's what you need to do with doing direct services and not knowing always what anticipated costs may arise. And then establish a budget for each region's delivery system, of which there would be input from the regional entities based on what their roles are to feed into that thinking. They would establish contracts with every provider, and those contracts would include the payment level. They would determine the methods of payment. They would ensure that they were adjusted for the reduction in administrative costs, because in this new world, they would only have one entity that they would be really working with instead of a multitude of insurance companies. They would be responsible, the single payer would be, for payment for covered services. They would establish and administer cost containment mechanisms. They would establish the budgets, as we talked about a minute ago, for the regional entities, with their roles of their work with the community and health improvement in the regions, as well as being sure that they had funding for regional infrastructure and capital investments, and delivery system innovation or health system improvement. And then also there should be a mechanism that the single payer would set up for itself to receive gifts, donations, and other revenue, perhaps as a foundation or whatever structure might be appropriate for that.
Yeah, I know we didn't discuss it, but you know, in the midst of COVID, I think one of the fiduciary responsibilities is to also sort of set guidelines or expectations for emergency preparedness, with particular attention to sort of marginalized communities.
What do others think about that in terms of also, is that just like any other, like as if you were a mega insurance company, because there's also public health's role in that emergency preparedness.
Right, and so I think that by them setting the expectation, they would kind of do the schematic, you know, in terms of if this happened, then this is how we're going to manage it, as opposed to having all of these, or at least 2 or 3 separate entities deciding for themselves how they're going to manage it.
Across the delivery system.
That's right.
Yeah, so sort of emergency planning.
Yeah, for the entire infrastructure. Now, it will take sort of back and forth, you know, to sort of tease out what the difference is based on geography and population demographics. But if we don't build into this plan thoughtful consideration around emergency preparedness, then we'll have this system that's going to be as dysfunctional as what we found in our current system.
John, do you have thoughts about that? I remember you and I checked in about including that within the scope of this charter back in the day. It feels like years ago at this point, but I think it was in March. Do you have anything to add?
Yeah. Well, I mean, I think when that conversation, I was wondering, well, is public health going to end up being in the single payer? And I think to some degree, we haven't talked about that directly, and so it's not in the single payer. I think if it's not in the single payer, I think the kind of statement that Deborah is talking about would be important, because I agree with her observation that under the current set of circumstances, frankly, I've been kind of confused most of the time. What is the organized delivery system doing? You know, and where is that conversation occurring? I mean, eventually, I think the state set up at least some places. I mean, the medical advisory group that Bruce serves on, for example. But I think it brings up the issue of if public health isn't in the single payer, should there be a formal statement and liaison and, you know, active process so that we're not caught like we were, you know, this time with, you know, all kinds of supply problems and allocation of resource problems and, you know, all of those sorts of things.
So something about working closely with public health, no matter where it lives in the future, around this area of setting contingency and emergency preparedness planning.
Yeah, I mean, it seems like in the scheme that we're now looking at, public health should just be able to come to the single payer and say, hey, step up here, let's go. You know, here's what we need the delivery system to do. Do it. Let's go. that would be my take on it, and all interested what others think.
I would agree that there needs to be a mention of preparedness. I think it could take a lot of different forms in terms of, what a single payer would need to pay and invest in times of an emergency. So I mean, I would just leave it. I probably wouldn't get too specific, but would leave it as establishes, continually establishes plans for emergency plans for emergency preparedness. Whether that's, a pandemic or a natural disaster or something else. I mean, it makes a lot of sense to me.
I might say I'm a bit biased. I did some consulting work actually for the state in the early 2000s around the anthrax stuff, but it had followed the epidemic in Toronto, and it was impressive what the single payer did. I mean, they gathered up the resources in Toronto and said, okay, all cases are going to go to one hospital. And so, heart surgeons at that hospital, you're not going to do heart surgery there for a while. Medical students, you need to go home. It's just too dangerous right now for the medical students to be around. And other hospitals keep everybody else healthy who don't have this disease. And that means, by the way, if you want to reach out to the heart surgeons whose operating rooms are no longer available to them, that would be great. Frankly, I think to some degree we operated in an environment of there was still like a market-based delivery system out there that kind of, in some respects did what it wanted to do, when maybe, more coordination on its part could have been helpful. I don't know. And anyway, I think it's a good topic.
Okay.
Deborah,
go ahead, Laurel.
Deborah, you were so good about bringing this issue up over the course of the provider reimbursement tag. And so I had flagged this as potentially something that needed further attention in a possible extension. Do you feel like this conversation has kind of wrapped this up for you? Do you feel like this conversation and incorporating it here, does this get at what you've been looking for?
Yeah, I think it does, and I do agree that we don't need to sort of mete out what it will entail, just so that we capture it as an essential.
Perfect. Okay, so I'll strike it from that list of outstanding questions. I'm so glad we were able to address this.
Yeah, I do have one additional question though that does wrap back into the provider tag. I know we talked a lot about diversity, both in terms of workforce and a focus. Is it the responsibility, as I would in my mind's eye believe, for the single payer to again lead some accountability that that all of our priorities and values around diversity as it relates to communities and having care that is responsive in that way, that they will be sort of holding folks accountable? Or would that solely be under the provider tag? Because I think that even if we hold it out under provider, if in fact a regional entity is not being proactive in terms of what their workforce looks like, wouldn't it be up to the single payer to, I don't know, encourage, promote, support, do something so that it's just not, oh, we tried, let's move on. Like, I don't know how we get to making that a priority.
I think it is in the roles of the single payer about workforce. And I think we're going to revisit the document where that lives, because I think John had some additional additions there, right, Laurel? So we could beef that up even a little bit.
You know what? I would actually suggest, I think I would like for more attention to be paid there to underscore its importance. And so I actually have drafted, in preparation for the May 25th meeting, I drafted a list of questions that I think need further attention. And this was one of them, Deborah. So I definitely think that there's like, we have said that the single payer is responsible for workforce recruitment generally, but I think it would be helpful to flesh out a little bit more what that means. And so we can talk about that at the May 25th meeting of whether or not we all agree that that should be on that list for a possible extension.
Yeah. Yeah, and you know, I would just add, I mean, one phrase that I added was, you know, expanding on quality improvement with concepts like safety and patient experience. I mean, how could you be responsible for patient experience and not include a focus and a priority for diversity? Because, you know, we just can't have patients having an experience that is racist. I mean, can't do that. And you know, we have seen difficulties with the traditional delivery system being able to sort that out. I'm not sure. You know, the solution obviously is really complex. It's systemic racism, but I would think the single payer would have a role to play. Again, money talks, and it would need to play a leadership role.
And am I muted? No. Deborah, it's possible that we just need one or two phrases in the current proposal that's already drafted, in which case I'll definitely take a look and see if there's a way to easily just tweak what we have. And okay, great.
All right, so before we leave this slide, is there any other input in terms of any missing fiduciary responsibilities, particularly based on your read of this?
I don't know that it goes under fiduciary, but I do like marrying cost and quality. So establishing and administering cost containment might be good to put in. Administers both cost containment and quality assurance mechanisms.
Okay.
I mean, and some of those could be financial incentives, et cetera. So it can fit under fiduciary.
So go hand in hand with the cost containment. Yeah.
I think they need to.
Yep. Okay. Chuck, anything? Are you still on?
Yeah, I'm sort of wondering, do we want to have any language, you know, the bill talks about it being a public trust. And I'm not sure whether we want sort of consistent with being a public trust or something added here.
Added to where, to the first bullet, or we're gonna have a section that talks about the public trust.
So maybe it doesn't. And I was just wondering, like, you know, establishes and ensures appropriate restricted reserves as a public trust or something, but it probably doesn't need it because we do have a separate section. So.
Others, any other thoughts? Okay. So we'll add in quality there. So we had this slide last time, just to show.
Can I just ask a question?
Go for it.
You know, Chuck, Chuck, at some point, maybe not today, I've been told by, you know, legal folks that fiduciary is a very challenging word. I've always found it to be pretty straightforward. You have a fiduciary responsibility. The needs for this person are supposed to come before your needs. But I've been told legally fiduciary is a challenging word and concept. And I like it sitting there because that's what it means to me, that the patient is first, the public is first. But, you know, maybe that's just me.
Yeah, I saw on mute.
No.
We can hear you.
Okay, so I mean, it does mean the patients first, but it's also has to do with sort of how you're sort of guarding the money, right? It's a fiduciary responsibility, you know, of a nonprofit board has fiduciary responsibilities, and that is to, you know, raise enough money and not to overspend and make sure that there isn't, you know, self-dealing and stuff like that. It's a broader term than just who's first in line, but it's all the other stuff to make sure that happens, that you're not doing self-dealing, that there's no conflict of interest. And so there's statutes, I think, you know, the nonprofit statute and other statutes have defined what they mean by fiduciary responsibility. And so, and the legislature will have to do that in creating this entity.
Yeah, I agree with that interpretation, Chuck. And I think as you've laid it out, that for me, it appropriately fits because I think that it does both of those things.
Right. And that's, you know, the bit about, you know, having appropriate reserves and all that, right?
So we are leaving the term fiduciary responsibilities and just returning to this concept of public trust in a couple slides. Is that the general consensus here?
Yeah.
Thumbs up. Okay.
Okay. All right. So we had this slide last time. It's basically, I think we tweaked a couple things, but that the single payer is a public trust. Key two components of it is to be separate from the state general fund, and it's designated only for the use by the single payer. So we took an attempt, and on the next slide was to try to capture that in a few more words. Some of this is stolen vigorously from some previous work that Ben Westland and Alan Bates tried to do in creating the Oregon Health Fund Board's public trust or fund, F-U-N-D. So we stole that and sort of adapted it here just for some response. If this, again, going forward, you're going to need legal eagles to come up with the proper right terminology, but this was language that was mostly all in statute previously for previous efforts around the similar end. So the trust is established separate and distinct from the general fund. It includes a variety of different funds, of which the title XXX and all that is the official names for the federal dollars. Contributions from the U.S. government, such as match and its agencies, such as what would be used for Medicaid. Money is appropriated through what the F&R group is suggesting. We did leave here healthcare premium contributions, although that's up in the air at this point, but potentially. Interest earnings from any dollars sitting in the reserves or others, grants, gifts, contributions for the purpose of carrying out the provisions of the single payer program. And they're continuously appropriated to the single payer to carry out the mission, and they may need to be segregated just because some of the Medicaid versus Medicare, we can take that off we don't have I'm not a legal eagle, so I can't tell you 100%, but that was what was there when we wrote this in statute back in the early 2000s, I guess it was. But this was just an example of trying to get at defining that trust a little more succinctly than just two little bullets. I don't know if you want to keep this or if you just want to stick with the two little bullets that are on the diagram.
I like this.
I like it too.
My only thing, I do too. I mean, I think it should have, it has money coming in from the state, only the ones that are appropriated. It seems like it could be, it should be, it also should have monies that are dedicated. So money won't be appropriate, it'll just be its dedicated funds going into it.
Oh.
I like that.
So the bullet that
Yeah,
says,
me too.
And that's so, and I think, you know, we want to the extent we can, and I think we'll have a fight over whether you can do it with income tax dollars, but you can certainly do it with payroll tax dollars, whether funds just automatically go there without going through the general fund.
so it would not be, so it'd
So
be
it's not
money
subject to-
both dedicated and appropriated, or just want dedicated?
Yeah, dedicated and appropriated, but
Okay.
Chuck, did I capture the edit correctly here? Is this the bullet point that you were speaking to?
yes.
Okay, good.
Deborah, John's seen this slide. I don't know if you have any other additional thoughts, either of you.
No, I like it, and I like the comments from Chuck.
Okay. All right. Well, that was easy. So we will, so that takes us to the section of when we're 10 minutes early. So yay. Moving on to authority. So these are sort of the things that the single payer, so if you were writing this in a statute, you'd say, okay, this is how the money comes in, and then you guys, single payer, are authorized to do XXX. So obviously, the legislature would first have to establish the single payer public trust fund like we just talked about, and they would have to establish and codify that there is a single payer program for the state. And then there would need to be outlined the following authorities. And we tried to, by going back through all those roles, responsibilities, et cetera, fiduciary responsibilities included, tried to outline kind of the key things that it needs the authority to do. So financial authorities, of which we've talked a lot about today, you know, that needs to set its operating budget. Now the question is how we put in here subject to legislative accountability. I don't know if you want it to be subject or if the legislature will want it to be. To set the budget for the regional entities, set up the reserves, be able to accept grant dollars. We could certainly also add anything else there, but those were the key sort of 4 financial authorities that the single payer would need to have. Thoughts, issues?
I guess I am wondering whether the incentivizing for any of the things we've discussed to date would fit strictly under what the budget is, or whether that would be in addition to the general operating budget.
Well, there's some further slides on this. So this is just the financial section. So hold that thought. And if it doesn't show up elsewhere, we will make sure we add it to. So as far as financial authority to basically accept and, spend its budget.
Well,
Janine?
John first, and then I think Chuck was saying something.
Yeah, as I listen, I think, well, that the SAFE have to get the legislature's approval for their operating budget. I bet they don't, but I'm not sure. But then again, SAFE is not using Medicare, Medicaid, federal funds. I don't think, but I'm not sure. I mean, it seems like there's also the governor. So there's this an interesting issue of who should the single payer have to have an approval from on an annual or biannual basis.
It does raise that issue of, you could say its budget's going to be, $50 million. And if it has the dollars to do it, then is that enough? Or does it have to be officially approved by anyone?
Yeah.
Now, that doesn't mean you guys have to decide that at this moment in time, but we did think about it as something to consider. Chuck, did you want to weigh in?
Yeah, so I guess I have a problem with establish it and codify it as a program, because this isn't a program like Medicaid or a program like the Oregon Health Plan. This is going to be, they're going to set up a form of public corporation. Public corporation, I think, is sort of the generic term, whether it looks like SAFE or it looks like OPB or it looks like what the Treasury Department wanted. And so they're going to establish the fund, and they're going to establish this public corporation that controls that fund. And I don't see them establishing it as a, when I read as a program, that means it's like a state, it's like Medicaid or like food stamps or whatever.
Well, it could be codified as an entity. We don't, to be TBD, a type of entity, codify it as an entity.
Well, I want to have it clear that we've talked about pretty clearly about being some form of public corporation.
I captured it in the decisions, Chuck. So definitely take a look at how it was captured. But I believe it was 2 meetings ago, we were pretty clear that we did not want to use the term public corporation because it has a specific meaning in Oregon. And so we wanted to use the term public entity.
Until you had more of a time for a formal legal analysis to decide.
Yeah.
Yeah.
So we were.
I'm not so sure public corporation does have its own thing, but that's a public entity is fine, but not a program. It's a public. It's going to establish the single payer as a public entity, separate and separate. It needs that language that says it's not, it's not that it's, so there's clarity that it's not under the control of the governor. It's not under, right? That's the problem I'm having with this language, that it isn't clearly that it's outside, it's like SAFE. So we could say a public entity like SAFE or OPB or after this, I'm not sure what the other public entity is.
Would it be worth just calling out that it's not?
OHSU is a public entity.
So how about codify it as a distinct public entity responsible for a universal publicly funded coverage for Oregonians, healthcare coverage for Oregonians.
And then Deborah and Chuck, I'm turning to you too as our resident legal eagles. Do you feel like it would also potentially be worth calling out that it is not under the control of the governor or the legislature?
I'm always for more specific than less specific, but I work in health policy, so what do I know?
But it could be worth just including in the recommendations, so that you're at least clear on the vision, right?
Yeah.
Okay,
But that's why I was thinking it's sort of saying. Well, I was saying such as, that's why such as OHSU and
add such as OHSU.
They're not under the control.
Yeah.
Although, technically
independent public.
Yeah, OHSU does get its budget approved by the legislature.
It only gets its state budget approved by the legislature.
Right. That's true.
Right.
then the legislature's no authority about how that money gets spent.
Wait, is it IF?
IF.
Yeah,
Accident
yeah,
insurance
yeah.
fund, yeah.
Yeah, insurance fund, good.
So the safe, responsible for providing universal blah, blah, blah.
Providing.
Does that sound more in keeping with what you were thinking, Chuck?
Mhm.
What do the others think?
Oh, I like that.
I'm having a little bit of concern about the language not under the control of the legislature or the governor. I mean, I think that goes without saying. I think,
By saying independent public entity?
yeah, it's
Yeah,
an
you can take
independent.
that out.
And because I think want to make certain that that sort of implies there's no oversight or scrutiny or anything. And I just think if this is going to be a transparent public trust, that there might be and could be and should be the ability of, some oversight.
Yeah. I mean, and there is. I mean, there's a reason why
Yeah.
the Secretary of State audits both of them, right? So, yeah.
Yeah, so we could just leave it like that.
And so just for the folks on the phone here, I'll read it out loud so that you can see where we've landed here. It reads, establish the single payer and codify it as an independent public entity, such as OHSU or SAFE, responsible for providing universal publicly funded health coverage for Oregonians.
Well, so I'm good with that. John, any thoughts? You good? If not hearing anything.
I'm good.
Okay.
So I just had a question, since we did bring up the audit, because that was the only other thing I didn't see in terms of, setting an audit schedule or auditing on demand, or like, do we consider, since it will be this entity, that we will just follow what is typically occurring, since this is a new process for the state? I mean, I'd love to be able to have this entity decide that, that they need to audit, either routinely or as needed if folks aren't being responsible with either the services or their budgets. So where would that occur?
It probably fell under the roles of oversight. It's probably in the proposal under roles. There was a line about operations, operating. It could also be put in the contracts with the providers in terms of audit function. We didn't go down into the weeds of all the various functions. But
Deborah, are you talking about?
It shows up someplace.
Yeah, but then there's the other issue of whether the state audits the single payer versus the single payer auditing the delivery system, right?
So then do we somewhere in this proposal need to call out at some point that, who is responsible for auditing the single payer? Is that the question you're calling, Deborah?
Well, I think I'm calling into both.
Yeah.
The way Janine just sort of outlined. Like, I think, yes, the single payer needs to be audited, since these are public dollars as well as, other funds. But I also think that the single payer needs to be able to audit these entities that will have a lot of autonomy in crafting what's going on regionally.
And I don't know what the rules and what Secretary of State already is allowed to audit, so I think somebody said they audited SAFE. I know there's annual reports that SAFE submits to the state. So it's probably will be tied up into how they set up the single payer, but an important aspect to me.
I liked what Deborah said, the bidirectional notion that The single payer will be obviously subject to audit and accountability, but by the same token, the single payer will have the ability to audit providers. It's the single source of payment. And that's no different than what goes on with Medicaid right now, et cetera.
Right. So
And I think,
Yeah, and then we'll make sure that the other auditing, their audit function is in the roles elsewhere in the proposal.
And I would say subject to audit, not necessarily by the state. I mean, it could be an external independent audit, audited, they'll have to have audited financials every year. I think we need to think about an audit in a number of ways, a broad scale audit of program and accountability, but there's a sort of, I would think annual audit of finances to assure that dollars are being accounted for appropriately.
Yeah, that's sort of one of those things in the financial in the fiduciary responsibility is to regularly audit, conduct regular audits. So I actually just looked up OHSU as a public corporation, and it's just, it just says public corporation means an entity that is created by the state to carry out public missions and services. In order to carry out these public missions and services, a public corporation participates in activities or provides services that are also provided by private enterprise. Public corporations granted increased flexibility to best ensure its success while retaining principles of public accountability and fundamental public policy. And so it's those details of that would be, we want in the legislation, but that's sort of what the overall, so public corporation is a sort of generic term that was defined when they created OHSU. There's probably another definition for public corporation elsewhere in the statute, like with SAFE or something, I don't know.
Bruce, I remember I think it was you that wanted to push for public entity as opposed to public corporation. How are you feeling about it now?
I still like public entity, and I'm just because I think leaves the door open. It doesn't shut the door on a public corporation. I think we just needed a bit more sort of legal underpinning work, et cetera. But I would lean that way, but I'm fine either way.
I'm fine with public entity. I just think we need to give guidance in this document about that. We want it to be a public entity that has the certain accountability, certain audit, fiduciary responsibilities. And I like the two-way audit thing too. That also, yeah.
And I do think the concept about the single payer auditing providers was captured elsewhere in the original enumeration of roles of the single payer. So I think we just need to add the second half of the single payer being subject to audit somewhere here. And I made a note that it's probably not under right now this bullet is under the legislature, and I don't think this belongs under the legislature. I think it belongs under the list of fiduciary responsibilities. And I'm seeing some nods. Okay.
Right, and they'll probably be subject to reporting requirements as well, I would think too. So, well, let's move on to the next few slides and see what else we've put on there to see if we're missing any, and then we can always, go back to that slide. So again, it would need to be set that the single payer can establish a board, which could have subcommittees, and they will be allowed to determine their board and committee governance structure. So they need the authority for that. They need to have the authority to have the oversight role and delegating any budget to the regional entities, as we've said they would. We had previously discussed at an earlier meeting about maintaining government to government relationship with the tribes, so they should be allowed to do that directly. And we did, John added this last bullet about needing government to government relationship with other states or countries. This might arise during multi-collaborative efforts for purchasing potentially, or alignment. So we added that bullet there. Thoughts about the governance authorities?
Yeah, they look good and I like the addition. I mean, under COVID, we saw that we had to scramble to search the world for PPE.
Unfortunately.
Exactly.
You know,
I
Right.
like that.
Trying to find pharmaceutical pricing. I think that's
Right.
maybe.
So they wouldn't have to necessarily go back to say, hey, governor, can you go negotiate for us? But they could maybe go talk directly, is I think the essence of what this authority would translate into. I mean, we have directly contracted with Washington State around the prescription drug program, so. Anything else on this one, this first half of the slide? Laurel, you were going to say something?
I'm wondering, do we need anything about eligibility or authority to apply for grants?
I thought we had it under the previous slide, fiduciary. Do you want to scroll back?
But do we need authority? Do we need to add that? We listed it as a.
It's sort of categorized under, no, not there. No, not that far back. Not that far back.
Sorry.
We had it that the payer could receive grants, but I suppose it would be thorough to say that they could apply for grants. You know, I mean, in Oregon, you do need to get the permission of the legislature to
That's true.
apply.
Right.
But go forward, Laurel, to the first authority slide. I think it's at the bottom. To accept.
Oh,
grant.
to accept. Well, yeah.
So to apply, so we could add the word to apply and accept grant dollars.
Yeah, I think that'd be good.
Okay. So the second half of this slide is sort of their administrative authority. So they would establish what the covered benefits would be. They would work through the regional entities with local governments on the single payer program. Well, we use the term program here, Chuck, single payer program. They would have the authority to contract with providers. They would have the authority to develop and implement payment methodologies and pay for covered services. They would be able to administer the program and ensure quality operations, which is a huge term and lots of stuff in it, including ability to subcontract for program administration if it was cost efficient, as you talked about previously, and to develop and implement program policies, single payer program policies. So again, we kind of rolled a lot of stuff up to bigger level authorities here.
Yeah, and I guess I'm just wondering if the contracting part is inherent in that is the distribution of funds. Because I see a lot of the things that would require money. And I don't know if it would be redundant to say that administratively they're dispersing the funds, but you know, just in my mind's eye, I can make the assumption based on what you have here.
Well, they do. The fourth bullet in that area says, and pay for covered services. And then the second bullet allows them to work with, and let's see. Yeah, I think it was back in that financial bucket is how we put it on the previous slide, that has them being able to put money out. Yeah, actually, they can set the budgets for the regional entities.
But I also thought we said that they were going to also get capital costs, and that's not payment for services.
No, that's not. The budgets for the regional authorities, regional entities would be for health improvement efforts and capital and infrastructure. So I'm wondering if some of these, instead of just setting up these, whether that second bullet needs to address your comment is to set and distribute the budget for the regional entity, so that the money is in the budget of the regional entity. All right, go back to that next slide. Are there other things missing? All right, so hearing nothing. John, any other thoughts about that slide before we start talking about the next one?
No, I'm good.
Okay. So this slide, I think, is the last of the set. So we had cost containment authorities. This could be expanded per our previous comment that Bruce had about adding quality in here. So it would be to implement quality assurance or quality and cost control measures. This whole section could be cost and quality. So I think the title should, the lump, we lumped them. But
Yeah, this is John. Again, I think at some point we might want to add, because quality improvement is just falls short for me. And I know that words like safety and patient experience are more meaningful to consumers.
So at the moment it reads to implement quality assurance and cost control measures. Do you want to add something here to ensure safety? What was there was a second component to that.
Patient experience.
Patient experience, right.
And would we maybe want to add equity to that to assure safety, equity, and patient experience?
Sounds good to me.
Good.
Okay. And then second half of that was to conduct bulk or multi-state purchasing approaches. You could theoretically add country if you're going to partner with Canada or something. And then the second half of this slide is addressing their authority to collect any needed data for tracking their spending, the utilization of services, reliable race and ethnicity information, so that to ensure that they can evaluate their overall system-wide performance, as well as, of course, being able to break it down by regions and quality. And then to also allow transparent access to the single payer population data. As we had discussed before, you wanted to be sure that people could really see into this data, with, of course, all the usual caveats of patient privacy, alignment with HIPAA, et cetera.
Yeah, I think under the data collection, what's missing from the race and ethnicity is also sort of the gender and gender non-conforming, because we want our services to be responsive, however our patients show up, and be affirming. So to not have that someplace in here, for me, is problematic.
We can easily switch it so it says both Real D and basically both Real D and SOGI, right? That's what you're getting at. Yeah.
Yeah. So but basically you're giving the single payer power over all this data. So they can, people can't refuse not to give them the data, and that they can get the data crunched and analyzed and out back to the public as well.
And then it would
Janine,
make,
oh, go ahead.
I was gonna say, under data collection and analysis, that first bullet, to evaluate system-wide performance, quality, and equity.
That sounds, yeah, that's a good addition. System-wide performance, quality, and equity. And then you're gonna add something after race and ethnicity.
Yeah, where is it?
Just to flag an issue here, I mean, my sense is this is a population health database. That's why I'm comfortable that it would be shared, the data would be shared with the public to, engage the wisdom of the community and strength of the community in figuring out what's going on. It's not a financial database. You all have just talked about audits and all, and at some point, we should probably talk more about, well, to what degree would financial data be public, etc. I'm not asking that we do that now, but I think data on the health of the population should be very public and all. Okay.
And I switched this so that it just says real D/SOGI. We can call that out in the write-up, but you guys want language too, right? That's what the L in the real is. And I realized language wasn't getting captured by just race ethnicity.
Yeah, because that'd be a valuable aspect for them to evaluate how things are going.
I'm wondering, do we need any clarity that it's not just the authority to collect it, but the authority to require the regional entities to submit it to them? I'm seeing Deborah nod.
But the regional entities are not going to be direct services providers. It's the delivery system.
Sorry, not the regional entities, the providers. You're right. So it's both the authority to collect it, but also the authority to require data submission, right? Or no?
I would agree with that. And I would go one step further in tying it back to the analysis to make sure that their programming and services are matching what the data is elevating, right? We're not collecting it simply for the sake of, housing it. We want to make sure that if you've identified you've got intersectionality, that you've done something to address it. So
well, we had put the language to collect any needed data. So that gives the single payer quite a bit of authority to ask for data. And no one can say, well, you don't have the right to collect it by giving them this authority. And so we left it kind of broad there. I mean, there's all sorts of aspects of what that data might be it actions, if they were doing quality improvements in projects, was there a closure of the referral to the housing system? What's their rate of closing, actually having those referrals get completed and something happens. So that's why we had left it as to collect any needed data. I'm not sure Laurel, if we have to add anything that says, I think it could go into the contracts with the providers as to what kind of data is going to be required to be submitted by the providers.
I apologize. I'm going to have to jump off now. Thanks so much for the collaboration. I look forward to seeing how the work continues.
Thanks, Deborah. You'll get an email from me soon.
Thanks
Excellent.
for your input.
Okay.
So do these last two bullets look adequate for now? Other thoughts? Chuck, or were you going to say something?
Yeah. So, allow transparent access, allow access, maybe, you know, allow opaque access, right? So
Well, I was trying to
Department of Redundancy Department.
well, you had said you wanted it to be a transparent data sharing or something. So I was trying to put that, you know, that it wasn't just like that it was as transparent as possible. So I wasn't, you know, it was a feeble attempt perhaps at getting the word transparent in there. Because there may be restrictions around some of the data due to HIPAA. So, but trying to be at least transparent as to, you know, if it was, you wanted to see it in some small region, how many people had heart surgery or something, then you might not be able to. So, but at least you could be told.
Right. I just think you could say allow access, allow access. It's not all their data. Their data would have to be subject to one of the current exemptions for us to not see it, right? Like HIPAA.
Right. So we can take the word transparent out if you want. Or
I mean, it could be transparently report population data.
As if the previous discussion was that people might want to ask for a look at the data. They often do for the all-payer database right now. And there's parameters around which they can see that data. And somebody controls, you know, whether it meets them, what they're allowed to see and when they can see it,
So we've changed it now for folks on the phone so that it just reads to allow access to the single payer population data.
Chuck, are you saying
Chuck,
something?
you're on mute.
What does population data mean? I mean, is that, I mean, all that stuff?
Yeah.
So it's to see the data that they're collecting, right? It's the performance, quality, and it's not just the data about how many gay blacks there are, right? That would be population data.
Well, we were trying to say, like, you couldn't, like, a provider couldn't say, hey, I'd like to know what my competitors are getting paid down the street. So can you tell me what so-and-so's data is? So I think we tried to keep it at that population level data. Because that was a request once for the all-payer database by a legislator.
I mean, Chuck, would it meet your needs if it just said to allow access to the data? You're on mute again, I think.
Yeah, to allow that to be just access to that data being collected in the first bullet, right?
Well, the authority is, the first bullet is just authority to collect. The single payer has the authority to collect the data. And then the second bullet allows the single payer to release some of that data. Doesn't say how exactly at this point, but to allow access to the above data would be it just allows them to let it back out in some manner. Does that look better to you, Chuck?
Yeah.
Everybody else okay with that? So for John on the phone, now the second bullet says to allow access to the above data.
Yeah, that's fine.
Okay. All right, on to the next slide. I think this one just acknowledges that there are additional authority that might be needed. Some of this the task force has touched on a larger level. And they might need waiver approval or law changes to allow them to function. And so we just put a listing down of those, including the Medicaid waiver authority to potentially will need an amendment to our current authority by the feds to allow the state, which is through what's called a Medicaid 1115 waiver, and other waiver authorities, because there's a bunch of other types of Medicaid waiver where you waive the federal statute. There would need to be a Medicare exemption. There would need to be some adjustments based off of language that's in the Affordable Care Act that oversees the exchange or marketplace. So 1332 waiver. There might be a need for an ERISA preemption. I'm not sure. And then federal budget neutrality, there might need to be some adjustments there, and state law or other regulations. We're not being specific on what all of these are, but we just wanted to acknowledge that there would be, of course, additional authorities that the single payer might need through these avenues to be able to use the money from the federal government that is coming into them with the addition of the federal programs. And these again are big lumps. Thoughts about this one?
I would segregate. I'd segregate. I mean, this one says we will need all of these, and I don't want it to say that about ERISA.
Well, this says these would include. We say we could change that.
No, it's well.
These could include.
But yeah, you say it will need adjustment and will need waiver approval to launch it. And it's sort of.
So that first sentence at the top could be changed to, may need adjustment.
And then the second one.
And
right.
may need waiver approval. These could include. Right. Okay, so be more non-specific right. in that intro sentence. Got it.
Yeah, and to change the would to could, right? So.
Yeah.
So that.
Because again, this is
we
part
all
of
know.
that.
Yes, we're going to need waiver one, but let's not design a system let's not have a report that says we need ERISA, but go forward with what we're trying to do, thinking that we won't run afoul of ERISA.
No, good catch. Good catch. Bruce, John, other adjustments?
Agree with Chuck.
Yep, looks good to me.
Okay. So I think that wraps up our authorities discussion. So you had the different categories. Do we want to go quickly back through them, or?
I think we got enough. Yeah, I think we got enough from this conversation. And then in a second, we'll talk through basically the process for you all reviewing the way that we capture all of this in the deliverable that will go out to the task force. So we'll get to that in a second.
Okay. So that turns us to a few things that on our discussions with John and that proposal, that Word document that you got as part of this meeting, that was the proposal that went to the task force. John had a few things he wanted to potentially suggest we augment or adjust on that document. Under the single,
Janine, I'm so sorry. May I just offer one additional piece of clarification here, because I did check in with John about this, and I think that some of this we may want to integrate into the proposal, and some of it we may want to just add at the end, sort of as an appendix of outstanding questions or questions for further consideration. Right. So I just wanted to offer those two. When you're thinking about this, you can kind of be thinking of those kind of three options, like definitely include this now, potentially include in an appendix, or actually you disagree and here's why. Those are kind of like the general level of feedback that we're looking for here.
Okay. Because that document did kind of go to the task force before you guys had another meeting. So there was, we wanted to make sure we touched on these. So under the single payer roles, he wanted to add something related to, they're going to be setting their budgets, et cetera. They wanted to transfer funds when able to address social determinants of health, just to identify that more specifically as something the single payer would have a role in determining. Anybody thoughts about this? I know the EBA tag spent some time putting, acknowledging the need to invest, have single benefits that would support or help social determinants of health, but we put it more as a sort of an additional thing in the EBA proposal. So I don't know if you want to add this or if you want to just add it as so the choices are add it into the document under roles on applying the reserve powers section. 2 would be noting it at the bottom of the proposal. 3 would be to put it off further discussion in the expansion as we get more better at refining what that whole social determinants stuff will be, how it will be handled. Are those the right, was there any more options than that, Laurel?
I'm a little confused as to where or how or who funds are going to be transferred from, to, et cetera.
Yeah, I think it was it was under the section where they would be sending dollars. Well, it's true. The way John wrote it didn't distinctly say. It could go that it goes to the regional entities as part of that infrastructure. It could just go out to be supportive via the delivery system. His comment was not specific as to where those dollars would go.
So is it transferring of funds or is it paying for services?
So this, I think that this, what John was trying, John, are you with us here?
Can you hear me?
Yes, now we can.
Yeah. My intention here was just to indicate that funds for social determinants would be kept at the single payer level and not be given to the delivery system to distribute. I just was putting a placeholder here because I think that's a good thing to do, and not to expect social determinants of health funding to come across in the budget for the delivery system. You follow me?
Yeah, no, that makes sense.
So it's outside the global budget.
Yes.
So we have one bullet under this, on that Word document, we have one bullet that says establish all aspect of budget, which includes, there's 2 things. And it says lead cost control efforts, support, the 3rd one is support regional economies, and the 4th one is transfer of funds. So that doesn't, sort of language-wise doesn't follow, but maybe it's
Invest in social
determinants of health.
In measures to address social determinants of health.
Yes.
Makes sense.
There's just that, yeah.
Well, I mean, measures, of course, to me means performance.
Oh no, I didn't mean. Well, I didn't mean that. It's just that you can't really. You don't want to. Social determinants of health are that you're in poverty, so you'd want to invest in something that would help reverse poverty. So you can't really invest in health.
And programs. Invest in programs and services that
address social determinants of health.
That address social.
Right. That address social.
Yeah. Again, all I want to accomplish is signaling it's not part of the health budget anymore. It's got its own budget line at the single payer.
Got it.
So the term social determinants of health is that only referring to the negative ones?
Technically,
I guess it does.
Yeah.
Okay.
Well, they're positive for the people who have them.
Right. I mean, raising the minimum wage is good, you know, increasing people's income, right?
Yeah, I mean,
social determinants of poor health, right?
So you invest in services and programs to address
social determinants of poor health.
But that's not what John's trying to get at. I thought it would be that John, if I heard you right, it was, you know, establish a separate budget for social determinants of health or something like
And
that.
you know what?
That's right.
I'm
uncomfortable we're going too far with this.
Yeah.
I just want to get them. I just want to communicate the budget for that stays at the single payer. And by the way, I think in this new wave of waivers that are coming along, Oregon and other states are asking for money for social determinants, and they're distributing it. That they're not giving it to the delivery system to distribute. Maybe I'm wrong, but I think that's. So this is not a new concept. In the past, it's been, well, the CCO, the money's in your budget. You know, you need to contribute 1 to 2% of your budget for social determinants of health, whatever you choose.
John, how would you feel about including this bullet point in the appendix as a list of topics to address down the line? I just want to flag.
That's fine. That's fine.
Okay.
That's fine for all of these.
Yeah. Okay. Because the EBA 2.0 group, or no, it was actually the first EBA group was pretty clear that they wanted further attention to be paid to social determinants of health and how the single payer addresses social determinants of health. And I feel like some of what you're talking about is kind of linked into that conversation.
Yeah. Is the rest of the group okay with that?
Sure.
Yes.
Okay. All right. So moving on, as Laurel tries to, we'll keep track of that. Under the workforce development section, there was a couple of bullets, and he wanted to add, ensure that the workforce is working at, and I use the term top of their license because that's what I'm most familiar with. John used the term top of their diploma. At the moment, the other bullets say identification of workforce needs versus capacity and work with stakeholders on approaches to address needed funding and training needs. So he wanted to add this one, that's a role the single payer would play, is to ensure that the workforce is working at, you know, so you're not having expensive doctors doing medical assistant jobs, et cetera, that you're really using.
Yeah, I mean, this was at the VA, and they did a superb job of it. You know, frankly, the best neurologist I have encountered in my career was the physician assistant in the neurology department at the VA who did all the intakes. And so he did all the initial diagnostic stuff. And he was just terrific and really smart, really helped out primary care, and, you know, saved the neurologist time for the most difficult case. Likewise in surgery, you know, the surgeons were in the operating room doing surgery. I mean, they saw patients and were involved in the evaluation, but, you know, it was PAs and nurse practitioners who were incredibly smart and you know, focused on one area, who did a lot of the pre and post-op stuff. And, yeah, you know, it actually was a wonderful environment for many of the surgeons and specialists to work in. But it had a very significant budget impact.
So it sounds like to me, the term top of their license, top of their diploma is just to, I guess, a layperson like me and a non-health junkie or whatever. That's not what I hear you saying. What I hear you saying is utilize people to the greatest extent or whatever. They, you know, maximize an efficiency. I mean, I'm not.
Well, it also is used in the primary care home world as, you know, just trying to use your MAs further that as far as their license allows, like they're not going to give clinical advice, but they can do a whole lot more than they historically used to just room patients. So it is that, Chuck, in that it's a combination of efficiency and maximizing everybody's to use them to their top of their capacity, but it's limited by licensing and their educations that they have.
Do you think if you ask the health committees in the legislature, what does working at the top of the license or top of the diploma mean? They would say that, or would they say what you just said, Janine? They would say, well, I don't know what that means, but I want people to, use their degree to their fullest. Or we rely on people, or however you just said it, was differently than that, because it just seems like it's a term that.
Well, we can get rid of the jargony term and come up with a different way to say it. But ensure that the workforce is working efficiently and maximizing the training of all of the team or something like that. But we can play with the words there. This also is a section, Laurel, where we might want to add in Deborah's earlier comment about equity. That section that would be where I would think it should go as well. Okay, so are we good if we play with the words a little and add this?
Yep.
Okay.
Yeah, take out the jargon, right? Yeah.
Okay.
That was what I was looking for.
Under the board section, John just raised the kind of a aspect that the key staff of the single payer will be recruited and selected and not be political appointees. And I don't know if you want to make that determination now or if that's something you want the single payer to determine at a future date.
No, it makes sense. The key staff will be recruited and hired by the board.
Yeah. Well, I added this after I both listened and read some stuff, about the demise, if you will, of the CDC. That the CDC director was not a political job until 20 years or so ago. And then it became a political job. And the hypothesis is that has played a major role in its problems. The same is true somewhat of the FDA. So again, this is a placeholder. We don't need to do anything with it now, but I wanted to put it out there for the second round and kind of get a read on you all.
So it sounds like people.
And you guys, I'm going to have to leave. So thanks for bearing with me. This was great. And I thought this was a great meeting, and thank you very much. Okay.
Okay.
Thanks, John.
Take care, John.
All righty. Bye-bye.
And the last bullet that John had suggested something be added on was under regional entities role, and that it allowed the entities to inform or provide input to the single payer on performance incentives and how they should be targeted and measured. And that would be bringing in that sort of regional stakeholder voice to this at the single payer level.
Makes total sense.
Okay. So it sounds like we can, except for the social determinants one that might go to TBD, further discussed at a future date, all the other ones with the right words will be added to the proposal, which you guys, of course, and Laurel's going to go through the review and finalization process for that. Is that what you heard as well, Laurel?
Yes.
Okay. So I think I don't know if there is a specific question that you want to ask the Consumers Advisory Council, since we had a fairly robust discussion today, and I'm not sure when the next CAC is.
You know, the last CAC meeting, there is going to be a CAC panel at the upcoming task force meeting. And I know that we're working to pull together a proposed list of questions to ask the CAC. So if there is anything that came out of today's conversation, we could certainly flag it as a possible question to add for that conversation.
So, well, if something comes up, you can always let Laurel know. It's, in this case, it was more anything related to the fiduciary or authorities of the single payer.
Nothing comes to mind at the moment.
Okay. So I know we have public comment. So do you want to go through the review process first, Laurel?
Yes, and we're definitely ahead of schedule. So we might have a chance to kind of check in on about the next meeting. But just generally speaking, this is going to go, we're going to go through the cadence that we've gone through with all of the tag proposals at this point, but just so that we're super clear on the timeline that we're working with here. Janine and I are going to work to integrate the feedback that we heard in today's conversation into the document that was distributed as part of your meeting packet for today's meeting. We'll integrate that feedback with track changes and comments, and then we'll send it back out to all of you by the 14th, which is this Friday, right? Is that the calendar? Okay. And what we're requesting is that you all take a look at that document and then let us know any edits and comments. And it could even be, John wanted me to specifically call out, as you're thinking through this document, you could similarly highlight questions for further consideration like he did. Sort of those 4 questions were questions that came to mind for him that he wanted the task force to return to in a possible extension with respect to the design elements related to governance. And you all could feel free to do the same thing, kind of flagging these items like John did. Janine and I will then work to integrate those comments back in, and we will distribute that document as part of the meeting materials for the May task force meeting. You all will actually meet once more before the May task force meeting. So that's just something to note in terms of this timeline. But the process for proposal review, we're hoping again that we will be able to have all of these edits done to the proposal by May 21st so that it can go back out to the full task force as part of the May packet. Any questions here? I realize when there's only 50% of the tag, there's really only 2 of you.
Well, I'll speak for 50% of the 2 that are left. Looks good.
Great, sounds good.
Looks great.
Okay, good. So I actually, since we do have a little bit of time, I did just want to kind of highlight that in advance of the meeting on the 25th, I have pulled together a list of questions that John and I worked on again back in March that seem like a list of outstanding design element questions that could make sense for the task force to tackle in a possible extension. And so I did just want to flag that list of questions, I'm really going to try to send that out to you all as soon as possible so that you all can be thinking through and really be thinking about those questions so that we can really use our time on the 25th to identify whether or not there are other questions that you all would want to consider tackling with respect to governance in the possible extension. So I just wanted to underscore that that document will be coming your way.
And Laurel, it's beyond, is it just governance related issues, or it can be broader than that?
I think at this point, the list that I have is broader, but there's a lot of gray areas, like what Deborah brought up earlier today with respect to workforce recruitment. You know, 770 calls out workforce recruitment within the context of the role of the board. It basically says like the report should include you know, specifications for the role of the board in recruitment and retention of providers. So recruitment and retention of providers in that context does fall under the board, but there's obviously other issues that are outside the role of governance. So I think there are a handful of items on that list that do have governance components, but also fall outside the scope of governance.
And when are you going to send that list out for them?
I'm not 100% sure, but we'll try to get that out within probably within the next week.
After you guys give us your feedback, of course. You can't see it until you do your feedback. Yeah.
Okay. I'm so impressed that we're not only finishing the charter one meeting in advance, but 15 minutes early. Is there anything else that folks want to just chime in on with respect to this meeting, or kind of wrapping up the charter here?
Okay.
Looks good to me.
Okay. So David, are you still on?
I'm still here.
There is.
Great. The floor is yours.
Same thing. I mean, a couple task force meeting, and I see four faces up there still. Yeah, this is an important aside, but it's an aside to kind of the point, or the setup points I want to really try to make. Someone said, you know, one provider wanted to see what the provider down the road was making. And I'd like to come back to a question I have. If it's a single payer, if the provider down the road is not making the same thing for the same, you know, things, is the provider asking that, there should be a good and transparent reason why that is, which gets back into the thing of what I wanted to say today. I see the emphasis of the single payer, the central entity contracting with the providers, but I did sit in on a lot of the provider reimbursement tag meetings, and the sense I got out of that was they were looking at the regions as sort of a super ACO. And, you know, I think we need to keep that in mind however we go. And even considering, you know, how much in total would each region get? I mean, would it be a pure per capita? Of course not. You know, would it be age, sex per capita? Probably not. Would it be age, sex plus chronic diseases? But what would that be? And I think that's important to keep in mind, because just like how in some models of governance that the states are the laboratories, or can be the laboratories for what works for governance, I think the different regions can be the laboratories for what is working and what's not. And I do see in everything governance is proposing so far, you're covering the basics, but I don't see enough emphasis on trying to drive innovation. You know, I think to me, for a lot of things, you want to know what you got to do. You want to know what you can't do. And in the middle, you get as creative as you can to do it better, to do it cheaper, to do it more rewardingly for, you know, the patients, for the providers, for the public. And also the data. I have 1 year of APAC data. I haven't started working with it yet. I plan to get 3 years. But I also see the cost containment group, and they're meeting again, I think, this Thursday, and I plan to attend that. They're working also on an augmented set, getting a lot of data that wouldn't be available in the all pay or all claims. But, I've been working with data for a long time. But I think a big component that might be wanted, might be needed, would be to get some of the data that's only in the patient medical record. And I think, almost all the providers in the state probably have an EHR. And I know that, excuse me, there's some incompatibility issues between the EHRs and the big player isn't very transparent. But again, considering that, yeah, I think those are my main points. Oh, yeah, one last thing. The whole social determinants of health, that would be the last thing I would be thinking about for, how you apportion the dollars and how you apportion the dollars per region. The CMS has a scale that they used for regions, basically on social determinants of health, regions more at risk for COVID. And I've seen another scale that seems to be pretty well validated on social determinants of health. So there are scales out there, at least to make a first pass at it. So I guess that would be a thing, at least to consider those, some of the work that's been done. But also, I say, to look at innovation, not only the quality assurance or cost control, but in there's a chance to get beyond that. That's about what I have to say now. I'll try to write this up in a a little longer and more coherent version, but I will bring up the whole thing about innovation and try to encourage innovation and even sort of cooperative competition between the regions and between providers within the regions to get better quality, better equity, lower costs, so they can go on to do some other stuff. I think that's a potent factor.
Thank you, David. We would definitely love to get those written comments, and you can send them directly to me or through the Joint Task Force email, which is at the end of the slide deck for today's meeting. And we'll make sure to highlight this innovation component, which I know is listed in the role of the single payer and regional entities relationship. So we'll make sure that stays there.
Yeah, sorry to back, because same thing with the getting everybody practicing at the highest end of their licensure, their diploma. But coming at that two ways, not only trying to recruit those roles and those people for those slots, but given the scarcity of most of those roles and most of those slots, how do you revise your healthcare delivery systems to get around that? So they're coming at it two ways.
Thank you so much. Okay,
Thank you.
everyone. I think that brings us to a close. I'm so impressed that we were able to get through all of this, and I will see many of you, I believe, both of you, I will see both of you on Thursday for the intermediate strategies meeting.
We'll be there. Thank you.
Yeah.
We'll be there.
Everybody.
This is our 770 week.
It really is, isn't it?
It's sort of every other one.
Yeah.